Now I would like to invite our esteemed faculty, Dr. Naina Patel, on the stage for next session. The topic is Role of Regeneration Medicine in Infertility. She is Medical Director of Akanksha Hospital and Research Institute and Ziva IVF. She is considered a first pioneer in field of IVF and surrogacy in India. She is from my hometown, Anand. I am attached by heart. And she is president of SOGOG 2010. She was invited to Oprah Winfrey Show, Heart Talk, TED Talk, and Josh Talk too. She has research interests include regenerative medicine, gut microbiome, ovarian and endometrial biomarkers, and PCOS. She is author of research papers, book chapters, and advances in assisted reproductive technology, and reviewer of many international and national journals. She has published world's first case of thin endometrium treated by bone marrow derived cell therapy. Dr. Naina Patel.
At the outset, I would like to thank the Indian Medical Association, Surat, Dr. Dipti Ben, for having me over here. I think I'm here for the second or the third time. First time it was on surrogacy. Again, Dipti Ben wanted me to speak on the medico-legal aspect of surrogacy this time, which now we have a surrogacy act like the kidney transplant. But I chose a different topic on regenerative medicine because that is the need of the hour for infertile patients. We know that infertility is on a rise. Nowadays, 15 to 18% of the couples, they need treatment for infertility. And it is going to increase day by day because of various reasons, environmental pollutions, unhealthy lifestyle, late marriages, etc. And the treatment options, before I start, I pay my tribute, it's not changing here, to Dr. Late Shankar Narayan, who is my mentor for the stem cell therapy that I do in infertility. So these are no more two different roads, I'll tell you at the end of the talk. When infertility is on the rise, the options we all know is IUI, IVF, ICSI. But what about the egg and the sperm in the uterus? So when the eggs are low, we tell donor egg. Sperm is not there, donor sperm. Or both not good, and donor embryo. And finally surrogacy because the uterus is not good. But the patient's desire is always that I want to use my own egg. Even at 42, they will say, why can't I use my own eggs? And we know that eggs are there by birth. New eggs don't develop like the sperms get manufactured every 2 to 3 months. So by birth, there are millions of eggs. By the time she starts menstruating, it goes down. And finally, 500 eggs are ruptured in a lifespan, and the other eggs are gone atretic. So a female will have low AMH, which is the marker of ovarian reserve, and that is when they are advised go for donor eggs, and they don't want to go for it, which I truly agree. And there comes the role of regenerative medicine. For primary ovarian insufficiency, you must be seeing girls of 30 years, 25 years having AMH 0.5, 0.05, etc. When the IVF cycles fail because the egg quality is not good, advanced age patient when the egg quality and quantity goes down. So we rejuvenate ovary with platelet-rich plasma, bone marrow derived stem cell, and we take out the piece of ovary and we activate it outside mechanically. Criteria to choose is their chromosomal makeup should be normal, 46XX, age up to 45, but we have done up to 48 also, telling them that it will not get good result. Autoimmune we have started doing because for a short period of time they can benefit. Hypothalamic causes should be ruled out. So platelet-rich preparation, everyone knows that it releases growth factors like VEGF, EGF, and which is put in the ovary. But the preparation technique should be very proper. We should know the platelet before, and that it should increase 3 to 5 times after the preparation. And once you activate the granules, they should be within 15 minutes put back into the ovary. This has been used for cosmetic purposes, for osteoarthritis, neurological disorders, but now in infertility, it's giving very good result. You just inject in the ovary after activating it. We do physical activation, freezing, thawing, the time when the patient is taken into the OT, and within 15 minutes we inject it in the ovary. This is the procedure for injecting in the ovary, and they will do it laparoscopically, because sometimes the ovaries are really small. You can't see them on the ultrasound properly, or they are stuck. That is the time we do it laparoscopically and inject it laparoscopically inside both the ovaries. Now, number of publications are there, and we ourselves have put up a publication in the International Journal of Fertility and Reproduction of our first 45 cases where we got a positive outcome of 27 patients, and it concluded that platelet-rich plasma ovarian rejuvenation helps. This was a homeopathic couple, both husband and wife, 0.3 AMH, one miscarriage, then not conceiving, was advised donor egg. They came to us, we did this treatment. Because they were doctors, they could understand that, yes, let us try this before we go to donor egg. We did it with the IUI, she conceived, and second pregnancy naturally. This couple from UK had read that I do this type of treatment in India. They had 2 IVFs. Their count was, AMH was reasonably okay, 1.56, but the eggs did not fertilize, and the doctors in UK said the culprit is the egg. So they said, we don't want to go for donor egg. They came here. We did their laparohysteroscopy ovarian rejuvenation in August. In March, she came for the cycle, but she never got a period. She had naturally conceived and delivered a healthy baby girl. This was just a 20-year-old girl with 0.04. She went to an endocrinologist who referred us for donor egg and hormone replacement therapy. They had religious issues where donor egg was not allowed. And 18 months later, after ovarian rejuvenation, she conceived and delivered a healthy baby. Now I come to the stem cell part, which is a revolutionizing therapy because it has been used for many indications, but getting a bad name again like PRP because not proper selection of patient, not proper technology, and the dosage, etc. is not properly monitored. So stem cells are cells which have multidirectional differentiation into all type of cells. There is angiogenesis, paracrine stimulation, and hence a promising future. If you see this ovary, which is the pointer, I cannot show, in the cortex, there are about 1,000 stem cells. Even in the menopause, they say there will be 1,000 cells in the ovary which can be used for stimulation and ovarian rejuvenation. So this is the typical picture. What we do, there is something called as stem cell nest and stem cell niche. Stem cell niche is a very hyperdynamic area where we can help it to rejuvenate the surrounding area where it is there. So granulosa cells are very important, vascular endothelium and ovarian reproductive cells surround it. Once the stem cells are injected in the cortex, they will homing in. They will go to the part which is injured because of the chemokine attraction. They will start the proliferation of the cells. They will start the immunomodulation. Apoptosis of the granulosa cell is improved, and finally the neoangiogenesis happens, immunomodulation happens. The bad environment in the ovary is microenvironment is improved, and ultimately endocrine function is also improved by secreting anti-inflammatory factors. We increase the TH1, TH1 and TH17 are reduced, Treg and T12 are improved. Lot of studies are there. We don't select the totipotent, pluripotent, like cancer thase, embryonic stem cell thi. No. When you use the embryonic stem cell, yes, but when you use the bone marrow or adipose tissue, these are mesenchymal cells. They have limited differentiation property into 2 or 3 cell types only. So what we prefer is the bone marrow derived stem cells. Proper counseling audio-visual consent is taken that this is an experimental procedure. Intravenous glutathione antibiotic, about 30 minutes of good oxygenation because we want the antioxidants to act, and then we go directly into the internal anterior iliac crest or the posterior iliac crest. It is done under anesthesia because the needle is quite wide bore, and about 80 ml of bone marrow derived concentrate we want. Females 50 also we are happy. And younger female platelets can give good results, but older the age, it has to be the bone marrow, and then we separate it with a separator. We have done almost so many cases every year. We started with one and then reached 120 cases in 2023. This is a couple from USA, lady from Bihar, and they settled in USA. Late marriage, 46 years of age, 4 pregnancies natural, all miscarriage, including one Down syndrome. She did one IUI there, failed, IVF failed, and she was suggested donor egg. She came to me in November 2022, first week. I said, I don't do beyond 45 years. She said, you do it, I'll write that I have done it with my consent. I will come to you for donor egg at 8 years of age. We did it January, bone marrow derived stem cell, ovarian tissue activation, rejuvenation. December 31, I get a message that I have conceived naturally. All her NIPT test, everything normal, no Down syndrome, and a healthy baby boy was delivered in July. This is the effect. So maybe the stem cells beyond regeneration could have some genetic effect also. This is a lady who is from Surat. She is 39, 25 years of married life, 1 ectopic, 11 IUI negative, 3 IVF failed. She was advised donor eggs, 0.862. January we did her bone marrow ovarian rejuvenation. We first egg pickup, 3 embryos, did not click. Second time egg pickup, she conceived, and now she is having her obstetric treatment in Surat. This patient has grade 4 endometriosis. You know, endometriosis is very bad. It literally destroys the ovaries. It was this bad, and her first cycle was done in Himachal Pradesh, where she was said that her eggs are not good, she should go for donor egg. She came to us, she wanted her own egg. See how far people travel just to use their own egg and sperm. We did the laparoscopic surgery. We again injected the stem cells in the healthy tissues, and then this was done, and then 3 months later, you can see that the healthy tissue is identified, and drop by drop we inject it, about 2 ml in both the ovaries, and per ml there could be 10 to 15 million mesenchymal stem cells. We did her IVF, 5 eggs, 5 embryos, and she has a positive outcome, ongoing pregnancy. This is an American lady with very high BMI, 0.49 AMH, cancer survivor, early cancer, where LEAP surgery was done on the cervix. She was also advised donor egg. We did her ovarian rejuvenation in December. April she comes. We get 1 egg, 1 embryo, and she has conceived. So in vitro activation, that is another form of rejuvenation technique, where what we do is we literally cut the cortex of the ovary, and then in the lab we put it for cutting it into very small thin slices. Patients really get afraid कि તમે મારી ઓવરી કાઢશો ને પાછી મૂકશો તો what will remain? મારા eggs બગડી નહીં જાય ને જે થોડા છે એ? No. There are secondary follicles which we need to activate. So once we remove the cortex, we don't take the medulla part at all. In the lab there are minor pieces done, and then with the infant feeding tube we put it below the mesosalpinx or in the ovary. So this is the lab procedure. I am not going into the detail. Once you put there, the hyposignaling will be disrupted and the ovarian tissue will get activated. This is the Japanese technique and Denmark technique that we have adopted. We have trained both the areas, and we have this team from Japan visit us last year in September for this particular technique, and we have been started doing it. This was the ovarian tissue activation, first case of India of live birth after this technique, which we have published in the Journal of Human Reproductive Sciences. Again, this patient from Surat, AMH 0.22, very irregular cycles. We suggested ovarian tissue activation in April 19. Of 3 cycles of IVF were done post-OTA, where we got 3 good quality embryos. We had known that we do it on one side of the ovary initially because we didn't know how good or bad it is. We transferred the embryo from the right ovary which we had done activation. She conceived but miscarriage. Then she conceived naturally. Her ovulation was on the right side, and the OTA ovary had this healthy baby which was delivered. Social egg freezing we are doing, but there is something as ovarian tissue cryopreservation. We should not hesitate for a female who is very young but has low AMH, not planning a baby, to freeze their eggs. Cancer patients freeze eggs or freeze the ovarian tissue cortex. So here what we do is we take out the cortex and then we freeze it. She may not want marriage, but her AMH is very low. How many eggs will you freeze? You can do 1 or 2 cycles of freezing. Cancer patient, if she does not have time for stimulation, we cut it. This is a special technique again developed from Japan, which we use it, and we save the cortex. When she wants pregnancy after 8-10 years, we can put it back in the ovary or in the forearm, stimulate and get her own eggs. This was just recently in July. 30 centimeter cyst on one side, the other ovary normal. Patient was taken for surgery in Karamsad. We planned the ovarian tissue cryopreservation. Frozen sample was normal. The professor said, when it is normal, why do we preserve? We said, no, we should still preserve it. We preserved the cortex. We have to go in a proper temperature maintenance of 37 degrees of the tissue and bring it back. Unfortunately, the ovary turned out to be cancerous, but now that reserved ovary, after 2 years, she can have her own eggs to have her baby. Another problem is thin endometrium. Tuberculosis, the endometrial lining is very thin. You will hear patient કે ગર્ભાશયની ગાદી બગડી ગઈ છે, ગર્ભાશયનું ગાદીનો વિકાસ જ નથી થતો, and they come for surrogacy after all treatments. But stem cells is now a rescue. They don't need surrogacy, majority of them in the ideal cases. There are stem cell niches in the uterine endometrium, in the basal layer. Uterus na endometrium na 2 layers. Functionalis is every month period away it sheds out. Basalis jyati fari it will start developing and develop into the functionalis layer. So here again there is endometrial niche which has got some patchy areas of the endometrium which we want to regenerate. Don't tell the patient કે તમને માસિક નથી આવતું, brownish discharge છે, lining નથી બનતી, you need surrogacy or adoption. Stem cell will help them. So this is our protocol for this. You can inject it in the intrauterine, but that is not giving much result. The other is the hysteroscopy. When you enter the uterus, clean up the hysteroscopically and subendometrially you inject it. But the technique that we have developed, and which is probably the first time in the world with bone marrow stem cells, mesenchymal peripheral cells, one center has published from Spain. So here what we do is, once the stem cells are taken in the OT, they go to our stem cell lab, and once the stem cells are prepared, we take the patient into the cath lab. Then, where is the stem cell niche? It is in the uterine artery which goes to the uterus endometrium and in the basal area. So with the catheter from the femoral artery on one side, we go to the hypogastric artery on the opposite side. Then we cannulate the uterine artery on that side. Once the uterine artery is cannulated, we pass the microangio catheters, and then we instill 11 ml, about 20 million mesenchymal cells. From both the sides we have to do it. So under anesthesia, we take the bone marrow, do the hysteroscopy. 2 hours later, patient is taken into the cath lab, and the interventional cardiologist, the radiologist or the cardiologist will see that it goes into the opposite, enters the uterine artery. And then, as a rule, one of us team member will be present in the cath lab at that time, and then they will inject. So you can see that it has gone to the uterine artery, it has microangio catheters have been passed, and then the stem cells. After that we put the fluorescent dye. So you can see it's going into the spiral arterioles. From the spiral arterioles it will come out, and the endometrium patches which are little bit remaining will be surrounding the spiral arterioles. The stem cells will go and home into that area. And this is, to the best of our knowledge, the first successful case in world of treating endometrial atrophy with this type of treatment, and it was published in the International Journal of Clinical and Experimental Reproductive Medicine. This girl had tuberculosis. She didn't menstruate only. Her lining was very thin. So they had 3 failed cycles and they were advised surrogacy. When they came to us, they could not accept surrogacy and afford surrogacy. So we suggested this technique and we did this in her. And January, the first 3 cases we did 19. Out of which 2 delivered, 1 had miscarriage. In May, we did her embryo transfer when the lining was better than before, and she delivered a healthy baby. This lady comes from Bangalore. Her embryos are frozen for 1 year. She had myomectomy, she had DNA done, and her lining was not developed. We did procedure, We prepared her lining, we sent her to the Bangalore to get the embryos transferred, and she delivered healthy twins. The doctor from Bangalore called us that what is the procedure that you have done. This girl, she is again from Surat. She had 11-year-old child, then 2 MTPs at 3.5 months. So the endometrium was severely damaged. We know curating is the worst. Endometrial polyps, tuberculosis. So she had then 2 missed, and her endometrial lining was totally gone. She had Asherman's. Both the walls were stuck to one another. We called her in January 2022. We did, because her AMH was also not very healthy, we did ovarian rejuvenation with BMDC, this uterine artery spiral arterioles procedure. We did again a hysteroscopy, there were some re-adhesions. IUI was done in August, she conceived and delivered a healthy baby. So then we published our pilot study of 10 cases of thin endometrium with bone marrow derived stem cells into the uterine artery spiral arterioles in the Journal of Regenerative Medicine, and we have now done total 41 cases since 2019, out of which 16 are positive, 9 delivered, 4 ongoing and 3 miscarriage. Last one slide or 2 slides of male infertility. Male infertility very low, oligoastheno, teratozoospermia, high DFI, stem cells has a role to play. PRP is there marginally, but stem cells, because they say that when there is idiopathic male infertility, there is a high prevalent diagnosis with no specific option. This might be associated with spermatogonial stem cell niche disturbance. So here also, this patient from Surat, huge history of tobacco chewing, 6 failed IUI, DFI was 61%, DNA fragmentation index. Sperm count hoy, motility hoy, but quality is not good. Again we did this procedure. First time we did IVF, no fertilization. Second time 8 blastocyst, and this patient from Canberra, same issue, husband had bad sperm counts, wife had got very poor reserve. We did both the things. We did IVF, 1 PGT and normal blastocyst. So we took the ethical approval from the hospital, health research laboratory, and the most important is the CDSCO, the government certification which is given to us for bone marrow derived stem cells for reproductive medicine. That is the indication that we can do, and this is the stem cell lab at Akanksha, which is as per the CDSCO guideline. You can see here, and with that I end my talk. This is just the lab, how it should be. It should be in 3,000 square feet with all the class 100,000, 10,000 areas with quality control rooms, hematological checkup rooms, infectious disease room, PCR room, the manufacturing unit, and whichever stem cell you take, at least 0.1 ml should be preserved forever. And you have to do all the infectious disease panel on it before you put it back in the patient. So I'll not go much into the detail, and I'll conclude by saying that stem cells has a huge role in patients with poor ovarian reserve, with male infertility severe where nothing works, and thin endometrium when nothing works like hormonal therapy or hysteroscopy. PCOS, we have started our pilot study and endometriosis, but most important, proper case selection, proper technology, and then only the patient will benefit. Don't give false hopes or promises. So now it is a hand in glove situation. With infertility comes the regenerative medicine, and thank you for the patient hearing, and thank you for giving me 2 minutes extra. In the thin endometrium, look, first we start with hormonal, then hysteroscopy adhesiolysis. If that also doesn't work and the lining is persistently thin, repeated fluid in the endometrium, the success rate in good selected cases, I would say is almost, we have done 41 cases, 16 conceived, ongoing trying. Only 3 cases we had no result, and we had told them beforehand, because when we put in the cath lab, the uterine artery were totally stenosed. There was severe endometritis. So there 3 cases did not get the result. 1 opted for adoption and the others are still trying. So I would say that if proper selected cases, it is as high as 70 to 80%.
Madam, stem cell treatment in India is banned by the DCGI. Except the clinical, purview of clinical.
That is what we have to do.
No, but they have not given permission to private sector.
They have given, the CDSCO is a national inspection from Delhi. They have given a designation as an orphan drug. So you have to have that permission before you start. It is a clinical experimental procedure that has to be counseled. There are protocols that you need to follow. And this inspection comes from Gandhinagar as well as Delhi. Once they approve your lab, they give you that you have to only do it for this indication and only bone marrow. So that way, and we have the DCGI approval also, but CDSCO is the one who gives approval for stem cells.
They give only your sanction under the purview of clinical trial.
Yes,
Otherwise
it has.
not for the team.
Yes,
Thank you.
but all patients who want it can come under the clinical trial. But we have to fill up all the details as per the CDSCO guidelines.
And what is
Question, madam, is the transfer of cells to the particular target organ, once there is a localized, suppose the knee joint or the uterus or directly you inject, when you are giving through the intravenous route, how can we make sure that it will reach to the specific target organ?
This is intra-arterial route. IV is just generalized. Intra-arterial, that's why. When we cannulate the uterine artery, we pass the microangiocatheters, we inject the stem cells, then we wait, then we put the fluorescent dye, and you can see the fluorescent dye going into the spiral arterioles. From the spiral arterioles, when it will come out? It will come out into the basal endometrium. And the basal endometrium surrounding the spiral arterioles has stem cell patches, and it will home in there. So that's why we confirm with fluorescent dye.
what is the success rate in case of ovarian failure, madam?
Ovarian rejuvenation is, we cannot say, but PRP and bone marrow stem cells has given very good results in the sense we have to select a patient. If the patient doesn't have at all any stem cells, the volume of the ovary is very shrunk, you have to tell them that maybe you may get a result or not. But if a patient has first miscarriage or a live baby, that means proven egg fertile, those patients, when the AMHS goes very down and they are advised donor egg, it is very good to suggest PRP or bone marrow, because here is the case where they will get a very good results.
Thank you.
It is a last hope before they go for donor gametes.
Ma'am, do you have any comparative study with bone marrow stem cell injection and PRP?
No, why not? Because what happens when we do bone marrow, we also take PRP, platelet-rich plasma. Bone marrow, when they are cultured, the mesenchymal cells in a platelet-rich plasma, they function better. So the potency of the bone marrow stem cells increase when it is cultured for half an hour, 45 minutes in the platelet-rich plasma. So that different study is not difficult, because in bone marrow also we utilize platelet-rich plasma as a base culture media. Yeah.
Thank you so much, Dr. Naina ma'am. It was a really informative, intellectual and interactive talk, to be very honest. So to felicitate Dr. Naina ma'am, I would like to call upon stage Dr. Deepak Patel sir and Dr. Deepali Solanki ma'am. Please. Thank you. Thank you so much, Dr. Deepak sir, Dr. Deepali and Dr. Naina ma'am.